One of the most perplexing of all psychological conditions is borderline personality disorder. Unable to find solutions to their myriad problems, these patients often resort to unpredictable and potentially dangerous actions.
Are you feeling like killing yourself right this minute?
These distorted beliefs and impulsive behaviors make this complex disorder extremely difficult to treat.
Everyone agrees now, borderline personality disorder is itself a predictor of suicide.
Marcia Linehan is director of the Suicidal Behaviors Research Clinic at the University of Washington in Seattle, where she is also professor of psychology and psychiatry.
This is the problem. The emotional pain that they experience can't be reduced, has to be tolerated, and they cannot tolerate it. And that suicidal behavior is ultimately an attempt to change that pain and reduce it.
Dr. Linehan recently published a book that outlines her approach to treating patients with borderline personality disorder. This program will present an overview of her treatment model, which Dr. Linehan calls Dialectical Behavior Therapy, or DBT. We will describe the main components of DBT, including a definition of dialectics, the goals of treatment, the various modes of therapy, and outcome data from a study Dr. Linehan conducted on the effects of DBT in the treatment of women who met criteria for borderline personality disorder.
I was thinking that was
Then, at the conclusion of the program, Dr. Linehan and Dr. Alan Francis, chairman of the DSM-4 task force, will discuss a number of issues concerning the treatment of these patients. The theoretical framework for understanding DBT is dialectics. Dialectics is a process of achieving balance. In DBT, synthesis, or balance, is sought on several levels. The desire for patients to change is balanced with acceptance of the patient's problems as they are. The goal of teaching patients how to solve their problems is balanced by the need to simultaneously validate those difficulties. A straightforward, somewhat irreverent attitude toward the patient's problems by the therapist is balanced by a reciprocal warmth and understanding. And finally, directly interceding in the patient's environment is balanced with teaching them how to interact on their own. Dr. Linehan's research on DBT is an ongoing process. Therefore, therapy sessions are always monitored. The purpose is to observe the behavior of the therapist and ensure adherence to the treatment manual. To illustrate Dr. Linehan's approach to treating borderline personality disorder, recreations and actual patient interviews will be used. However, to maintain patient confidentiality, the images have been electronically altered.
What we've got to do is we have got to figure out a way, you and me, to change this behavior.
I don't think I can change.
Dialectical behavior therapy draws from traditional cognitive behavioral models, particularly those that emphasize change-oriented strategies. But in developing DBT, Dr. Linehan added an important element.
When you approach people who meet criteria for borderline with a treatment that focuses exclusively in helping them change, what you find is that the individual is so sensitive to negative feedback and criticism that their ability to change gets reduced and diminished and goes to almost zero if you come in with what I think of as a technology of change. Well, I know it's going to be really hard, but between the two of us, we are going to have to do it. Throughout the entire treatment, what I've done is gone to other treatment approaches besides behavior therapy and looked for what I now think of as a technology of acceptance. And so what I brought in was acceptance-based treatment strategies, blended them in with change-based strategies. And so the treatment now is really defined as the balance of acceptance and change. let's see, your boyfriend starts a fight, you lose it, he walks out, you decide it's over, decide to kill yourself, walk into the bathroom, pick up your pills, take them all, and practically die.
In DBT, the objective is to address the behavioral characteristics typically found in patients who meet criteria for borderline personality disorder.
The treatment itself is based on several kind of interrelated sorts of ideas. The first idea is that people who meet criteria for borderline have skills deficits or capability deficits, that they don't have the ability to engage in the behaviors that they need to solve their problems. What I'm thinking is that what we have to do is teach you something new to do. What do you think?
I think that would help.
You want to learn something new?
Yeah,
Okay.
I have to.
Well, I agree with that. The second is that the individual, even when they have the capabilities, often does not use those capabilities because of motivational factors. So they're inhibited, they're being punished for being skillful and rewarded for, say, suicidal behavior, for example, or they have faulty beliefs. And so we have a whole component where the real function of the component is to focus in on motivational factors.
Well, at home, no one pays any attention to me. People just tell me to shape up. At least in the hospital, people take me seriously.
So one of the things that's going on here is that if you try to kill yourself or say you're going to try to kill yourself, that's the effect of that is that other people take you seriously.
Yeah,
Okay.
it's the only way they'll take me seriously.
This, of course, is the problem. People take you seriously in the hospital. And being taken seriously is a reinforcer for you, I'm almost sure. It's a reinforcer for most people. And so if you get taken seriously every time you say you're going to kill yourself, or when you do try to kill yourself, and you don't get taken seriously any other time, you can count on it. You're going to keep threatening or keep trying to kill yourself. That's just the way it works. The third assumption is that the individual needs help taking what they learn within a treatment program and applying it in their everyday world, and that a lot of treatment programs fail because they don't pay enough attention to getting the behaviors learned in therapy into the real world where they've got to have them. And so we have a component whose aim is to provide coaching in use of new behaviors in the everyday environment. And in at least the treatments that we've researched to date, that has always been done with telephone calls to the individual therapist. Although one could do that with case management, milieu treatment, and a lot of other things.
I don't see what good learning these skills does. I mean, it's like I'm learning to be the perfect patient, but I still can't function outside. It's like I get into a crisis and I still can't do anything.
Well, listen, that is the point of the phone calls. The whole point is for you to call me, and then I'm going to do some coaching with you on the phone so you can practice the skills out there, because I completely agree with you. It doesn't do you any good to be a perfect patient.
The goals of treatment, then, are to bring about both change and acceptance by replacing maladaptive and ineffective behaviors with appropriate and effective ones, and to improve the patient's motivation to change. In DBT, treatment takes place in several different contexts. These include individual psychotherapy, group skills training, telephone consultation, consultation meetings for therapists, as well as ancillary treatments, including pharmacotherapy, inpatient care, day treatment, case management, and support groups such as 12-step programs. These different modes of therapy each function in specific ways. For example, each patient has an individual psychotherapist who is also the primary therapist for that patient on the DBT treatment team. The role of the individual therapist is to first orient the patient to the therapy, and have the patient agree on treatment goals even before therapy begins.
You do realize that if you don't drop out for a year, that really does, if you think about it logically, rule out suicide for a year.
Logically, yeah. But since when is suicide logical?
That's part of the reason we're having this conversation, is to try to structure our relationship so that it's very clear for both of us. And that way, at least, you will try to cut down on how much you get overwhelmed by not knowing what's going on with me.
Right.
Okay?
Then the therapist should target all life-threatening behaviors.
Now, one of my goals that we need to get agreement on is that kind of independent of what your mood is, that you won't try to kill yourself again. That, to me, is kind of the most fundamental mood-related behavior we have to work on, is that no matter what your mood is,
Right.
you won't kill yourself, or try to.
Right.
Next, address problems that affect quality of life, teaching coping skills to use in place of habitual dysfunctional behaviors.
So one of the tasks for you and me would be to figure out a way to get your behavior and what you do less hooked up with how you feel.
Right.
I think we could deal with it, but I think it's going to be hell. And the real question is whether you're willing to go through hell to get where you want to get or not. Now, I figure that's the question here.
Well, if it's going to make me happier, yeah.
You sure?
Yeah.
Okay. That's good, though. See, that's going to be your strength. We're going to play to that. That's our friend, this desire to live. You're going to have to remember that when it gets hard.
Therapy interfering behaviors by the patient or the therapist must also be attended to.
We've already talked about suicidal behavior. Now, the second really important thing in psychotherapy with anyone, and in particular in this therapy, is going to be for you and I to spend whatever amount of time we have to working on our relationship. And what I mean by that is that we're going to work on any of your behavior that creates problems in therapy. And just as important, we're going to work on any of my behavior. So if you do something that creates a problem for me or for the therapy, I'll bring it up if you don't bring it up first. But if I do something that creates a problem for you or for the therapy, then you bring it up if I don't bring it up first. And then we'll work on that. Because the whole idea is that you and I, we have to work together well.
And finally, efforts are made to generalize these skills into daily life.
Okay, you're already ahead of the game because you agreed last week not to kill yourself before this week, and here you are alive.
Yep.
So you did that.
Yep.
Is it hard?
Yeah.
That's good. Now we know you can do hard things.
The heart of individual psychotherapy is the application of DBT's core strategies, validating the patient's problems, while at the same time trying to teach the patient how to solve those problems.
You have to choose whether you're going to focus on it completely and feel really bad, or whether you're going to do some distraction.
In most therapies, validation involves concepts such as empathy, listening, and reflecting back. But in DBT, validation has additional meaning.
DBT does all of that, but it adds on one thing that is not as often talked about in other treatments, which I call validation in terms of the present. And that's the requirement within every interaction, that the therapist search for the grain of wisdom or the grain of truth in the patient's response in the moment. So that's the response where the therapist is looking for and commenting upon something about what the patient's saying that makes sense in terms of the present.
I don't like myself when I get angry. I don't like it when I end up attacking a friend of mine.
Well, I can sure understand that. I mean, I can understand not liking that.
I mean, I hated myself for it.
So, you're hating yourself for getting angry?
Losing it. Not just getting angry, but really losing it.
Well, I gotta agree with you. It sounds like knocking your friend to the ground is losing control. So you felt out of control when you did it?
Yeah.
Any other feelings that you're having?
No.
So how'd you get from there to strangling yourself? That's what I don't understand.
'Cause it works.
For what?
Makes me feel better.
Well, I can see how it does that. It's kind of like taking a sleeping pill, isn't it? I mean, it makes you unconscious.
Yeah.
This gets misconstrued constantly by people who try to learn this therapy into thinking that if you ever invalidate behavior, you're not doing the treatment. So the idea is not to validate the invalid. It should be sort of paternalistic if you didn't. The idea is to find the valid. So it's based on the premise that it's there and that you can find it. And so far, I've been at this for quite some time, I have to say, when I've looked, I have found it.
In DBT, validating the patient's problems is balanced by teaching the patient how to go about solving them.
And in problem solving is included, first, the notion of behavioral analysis, which is a very in-depth, moment-to-moment, second-to-second analysis of the chain of responses that led up to problematic behavior. And so it's essentially the therapist trying to make sense with the patient of the patient's behavior.
You had urges to hurt yourself really starting on Wednesday, huh?
Mm-hmm.
Do you know what set them off on Wednesday?
It began to hurt.
So you started having a lot of pain. Now, when did you start having the pain, and when did the urge to harm yourself come?
Same time.
They just come at identical moments?
Just about.
So how is it that feeling pain sets off an urge to pain? Do you know how that goes? How you get from one to the other?
I believe firmly that if I'd gotten pain medication when I really needed it, I wouldn't have even thought of self-harming.
You know, you are not the first person I've ever met that if something hurts and no one will help them, they make it hurt more. It's kind of perverse logic.
Especially when it doesn't work.
Let's imagine for the moment that you and I are on a raft together out in the middle of the ocean. Our boat has sunk. We're on the raft. And when the boat sunk, your leg got cut really badly. We have no pain medicine. And we're on this raft together, and your leg really hurts, and you ask me for pain medicine, and I say no. Do you think that you would then have an urge to hurt yourself, make it worse?
If you had the pain medication...
No, I don't have any pain medication.
No, it'd be a different situation.
Okay, but if I did have the pain medication, I said, no, we have to save it and only have one a day. What do you think?
Well, if that were logical to me, I'd go along with it.
You wouldn't want to hurt yourself? What if I said no, because I don't want you to be a drug addict?
Want me to hurt myself?
Okay. So we've got this clear. So actually, your hurting yourself is communication behavior. Okay? So what we have to do is figure out a way for the communication behavior to quit working.
Why?
Because if it doesn't, you're not going to stop doing it until it quits working.
Balancing that is what we call solution analysis. And solution analysis is the therapist trying to help the patient figure out what they could have done different. So it's like if you were driving from Seattle to Florida, but you ended up in New York. Behavioral analysis is trying to figure out how in the world you ended up in New York. Where did you make the wrong turns? And solution analysis is trying to figure out what you could have done to get to Florida. So that's basically what it is.
You see, what I think is happening is that when you're in a lot of pain and you feel either not cared about or not taken seriously, invalidated, that's what sets you up to hurt yourself. And I also want to die. And that what we need to do is figure out a solution to that problem so that there are other ways to get out besides hurting yourself or trying to kill yourself.
So that's the main part. Then you have to add on to that sort of a commitment to go to Florida. So if you end up in New York and you figure out how to go to Florida, it's not very useful if you can't get the person to agree that the next time they get in the car, they are going to Florida. And so that's the sort of ending part. So you analyze it, you figure out a solution, then you get a commitment at the end.
At times, Dr. Linehan's response to the patient may seem blunt and somewhat irreverent.
I've been going through this since I was 11 years old. I'm sick of this shit. Either I need to do this or I need to die. Those are my two choices.
Well, why not die?
Well, if it comes down to it, I will.
But why not now?
But this is not a matter of personal style. In fact, it is a planned part of dialectical behavior therapy.
What DBT says is that a therapist needs to balance their styles, no matter what your personal style is. The irreverent style combines a number of things. Part of it combines just a lot of confrontation, bluntness, calling a spade, and being direct. And if you try being very direct with borderline patients, you'll be amazed because they almost always love it. They'll almost always tell you they really appreciate it. This is what people tell us all the time. So that's the confrontation. That's part of irreverence. Now the other part of irreverence is it's hard to describe in words. It's the off-the-wall part of it. It's the sort of being outrageous. It's the where you don't exactly censor everything. And it is the attempt of the therapist to sort of push the patient into some other way of thinking. So it's a lot of use of paradox, taking small parts of what the patient says maybe and exaggerating them, or picking up a part that they didn't want you attending to and attending to it, etc.
Kind of the most fundamental mood-related behavior we have to work on is that no matter what your mood is,
Right.
you won't kill yourself, or try to.
I agree with that.
Why would you agree to that?
I don't know.
I mean, wouldn't you rather be in a therapy where if you want to kill yourself, you can?
I don't know. I mean, I've never really thought of it that way.
That, though, can very easily become mean-spirited, be used against the patient, be sarcastic, and be used to justify no end of troublesome behaviors. So, balancing that is what I call reciprocal communication. And reciprocal communication also has a lot of parts to it, but the main part of reciprocal communication is an emphasis first on warmth and genuineness, and responsivity of the therapist. So it's much like being vulnerable, which also a lot of other therapists have talked about. Interestingly, Jung talked a lot about the necessity of a therapist being vulnerable. And being vulnerable means that you had to be touchable, you had to be pushable, you had to be movable. The patient has to be able to influence you by what they do. And I don't know how you can learn this. It's intuitive or something or other.
Being irreverent is not easy to accomplish. Such a direct style may not be part of a therapist's training or personality.
I tell teams all the time that the way to learn irreverence, if you're not irreverent, is to find the person in your group who's naturally irreverent, because there's always somebody who's this way by birth. And whoever it is, then you listen to every irreverent thing they say, and you have to get them to tell you all the irreverent stuff, and then you imitate them.
I like the style of DBT. I think I'll have to work at it some. It's irreverence is something that will take a lot of being able to relax with people. I think that takes a certain confidence that I'm still building in doing therapy with people. But I think that it will open up for me a lot of room to be more of who I am, because I find myself being that way more with people naturally. And I think it opens up a lot of freedom to move with patients that I didn't feel like that I had so much before.
You're dancing with your client the whole time, and so it keeps you real focused. So you know when you're on one side of the dialectic that quickly you're going to be moving, and so intellectually it's very satisfying, and it's fun. I mean, it's a fun thing to do.
Individual therapy focuses on motivational issues. However, group sessions are used to enhance social capabilities through psychoeducational skills training.
A lot of times I could get so anxious about something that I just blank out or something, At that point, appearing confident seems almost like
it seems like the hardest thing to do, yeah.
Yeah, I mean,
that might be something that you need to practice more.
The goal of skills training is to replace the negative emotions, beliefs, and behaviors associated with borderline personality disorder with positive ones. Because skills training is difficult to do within the framework of individual therapy, patients are required to attend these group sessions as well. Within the DBT protocol, two types of skills are taught.
The formal skills are divided into two sets of skills. The first are what I think of as the acceptance skills, and the second are what we call the change skills. So the acceptance skills are also divided into two sets. The first part is the mindfulness skills, which are really skills that have to do with being able, learning how to focus your mind in the moment that you're in. So it can be thought of as radical acceptance of the moment and mindfulness of the moment.
Mindfulness skills encourage patients to balance a rational reaction to a situation with an emotional one, a state called wise mind.
M is mindful, which means that you want to stay focused.
When successfully practiced and integrated, mindfulness skills help decrease identity confusion, feelings of emptiness, and cognitive dysregulation.
And the second set of skills that are also acceptance-based are distress tolerance skills. And these are skills that have to do with, in effect, how to get through a crisis or a tragedy that can't be made better when you can't make yourself like it, but you've got to survive it anyway. So they're crisis survival strategies.
Distress tolerance skills teach patients who are in pain to distract, self-soothe, to make attempts to improve the moment, and evaluate the pros and cons of the situation and their response.
So you were thinking if you hurt yourself, they would somehow give you pain medicine?
If they wouldn't listen to me, then I could show
Okay, you were thinking that.
them.
That if they won't listen to me, I'll show them.
Uh-huh.
Okay, so why didn't you do it right then?
Didn't want to make it worse.
So you were thinking about what? You were thinking about pros and cons. If I make it worse, I'll feel worse? Okay, so that's good thinking. That's when you're thinking that. You're thinking about the advantages and disadvantages of doing it.
Mm-hmm.
Okay.
When properly implemented, distress tolerance skills help decrease impulsive behaviors, suicide threats, and self-injury.
So those are the two acceptance-based skills. And those are the ones that are most different from behavior therapy, is those two sets. Now the other two sets are sort of standard behavior therapy skills that are in many behavior therapy programs, and so there's nothing too unique about them. The first is interpersonal effectiveness skills, which is in effect how to be effective in conflict situations. In particular, how to get what you want when you're asking for something, and how to make your no stick when you're trying to say no. How to stand up for yourself, asking and saying no.
I'd like for you to think of some situations in your own lives that we can practice with.
This skills training group includes both family members and patients. They will be practicing an interpersonal effectiveness skill called Dear Man. This exercise is adapted from a similar one developed by Bowers and Bowers of Stanford University. Each letter serves as a reminder of the target behavior that patients are taught. These are: describe the current situation, express feelings and opinions, assert by asking or saying no, reinforce the person ahead of time, be mindful of objectives without distraction, appear effective and competent, and negotiate alternate solutions.
What I want is for Kim to ask and you to try to respond, but we're also going to be looking not necessarily to solve the problem, but also to look at afterwards how you felt about the way she phrased it, and Kim, how you felt with how he responded.
It seems to me that you've been awfully interested in the things that I'm doing in my day program, and the people that I'm hanging out with, and the people that I'm dating, if I'm dating, and every little thing that I do. And you keep asking me questions, and I understand that maybe you're interested in my well-being, and I really do appreciate it. But I really feel overwhelmed.
Improving interpersonal skills helps decrease feelings such as interpersonal chaos and fears of abandonment. The second set of change skills are called emotion regulation skills. Regulating emotions allows patients to decrease feelings of anger, fear, shame, and sadness.
One of the reasons why
Again, the aim of group skills training is to meet specific behavioral deficits associated with borderline personality disorder and to replace them with positive beliefs and behaviors that will help patients learn to solve their own problems.
You know, even though I knew that this was just
role play, I started really feeling like, oh no, you know, I really can't do this on my own. I really do need to depend on mommy and daddy. And these aren't even my parents. Oh no,
Oh my God.
disasters. You
So
know.
what got you back? Because you didn't react that way.
Well, you know what it was? It was focusing in on what I was doing and what I was trying to get across.
Being mindful.
Being mindful.
Right.
Yeah.
These and several other psychoeducational skills are described in more detail in this training manual written by Dr. Linehan. The manual also contains worksheets suitable for reproduction and distribution. Treating patients with borderline personality disorder can be a difficult and often frustrating experience for therapists.
And Wednesday she missed my session, didn't call, which is unusual for her, didn't return my call until I reached her next morning, lied about why she didn't make it.
She's now missing in action again and has been since, I guess, Friday night, which is her pattern. I mean, this is her consistent pattern of working Monday through Friday. She's like got apparent competence down. I mean, she's just amazing.
She has spent more years fooling doctors than I have been a doctor. Right. And she's done it as a life and death issue every day. I'm not that good.
To help therapists cope with these patients, DBT takes a team approach. Just as there is consultation to the patient by therapists, there is also consultation to therapists by a team of colleagues.
The consultation to the team is based on the notion that the relationship between the patient and the therapist is a reciprocal one, and that the patient's behavior can have a very important influence on the therapist's behavior, and that what often goes on in treating borderline patients in particular, and possibly many difficult to treat populations, is that the patient often inadvertently reinforces the therapist for doing essentially ineffective treatment and punishes the therapist for doing effective things. And that what happens over time is that the therapist slides from a treatment that might have been effective if they had stuck with it to one that progressively becomes less and less effective over the time because of this reciprocal interaction.
When I went through my most difficult session to date with my patient, you know, and I knew the right thing was to call, like, this is where I need the team to treat me so that I can figure out how to treat my patient. I think had I had a system like that in place, it would have been easier for me to at least make contact with that person. But part of what I was going through was like shame, humiliation, all of this stuff that like...
So the goal of the treatment team is to consult with the therapist and provide a balance to the patient and a balance that will keep the therapist within the treatment frame. So the goal of the treatment team is to reinforce the therapist and support the therapist in doing effective treatment and help give them feedback when they're doing ineffective treatment. And at the same time to apply all of the DBT treatment strategies to the therapist. So what they do, what the treatment team has to do, is a balance, validation of the therapist. So the therapist comes in ready to kill the patient, and the treatment team says, well, of course, how could you feel otherwise? That's the validation part. And then the change part is the problem solving, but what are we going to do about it? Because that attitude is probably going to be harmful in the long run. So that's what that team does. And it's a weekly meeting. It's become so important in this treatment that I now believe that it's an essential part of the treatment. It's as if I've redefined what I think treatment is. I used to think it was a relationship between a therapist and a patient, or a therapist and a patient group. And I now think that it's the relationship between the patient and the therapist, and the relationship between the therapist and the team or system. And it's that whole circle. That's the treatment. So the goal of the treatment team is to consult with the therapist and provide a balance to the patient, and a balance that will keep the therapist within the treatment frame.
My experience in working with borderlines as a case manager was that though there were people around, I felt very much that I was doing the work on my own. And I think that what I'll be able to get from the team is a much more ability to be able to live with the sorts of issues that borderlines present on a daily basis.
the fact that mental health practitioners are really supporting me, and I in turn are supporting them, and that we don't have to look for that affirmation from our clients, is that we're working together on this, and we know that there's somebody that's supporting us, so you don't have to feel so alone in dealing with your client.
The goal of dialectical behavior therapy is to help people with borderline personality disorder find hope and forge a life less encumbered by emotional chaos. But how effective has DBT been in treating these patients?
There are a lot of ideas that people have about how to treat these patients. What this treatment has going for it at the moment, which others may have before long, but at the moment it's the only one that's got this going for it, is a control clinical trial data demonstrating it's effective.
Dr. Linehan conducted a one-year study of DBT, treating 24 women with a history of suicide attempts and self-injury. These were compared to a control group of 23 similar women who received standard treatment. The number of self-injury attempts among the DBT group was nearly half of the control group. And the number of hospital admissions over the same period showed that, again, there were half as many from the DBT group as the control. However, despite these improvements in outcome, Dr. Linehan does not consider DBT to be a cure for borderline personality disorder.
I think we had to be completely clear about something, which is this treatment is not very good. It's the best, but it's not good. We don't know how to treat these people well. What we can do with this treatment is as much as we can do, but we simply got to do better than what we're doing. And this treatment's got to get better. And this is why I'm fundamentally a researcher rather than a practitioner. It's because someone's got to stay home and try to make this thing better. And so that's really what I'm doing, is I am continuing the research, trying to improve it. And hopefully it'll keep improving, and many people who apply it are going to make it better, and community mental health centers are going to make it better, and managed care is going to make it better, and hospitals will make it better. In other words, I think everyone who uses it probably will be able to contribute and make this treatment better.
For most clinicians, for most family members, for most people with these problems, the most devastating and terrifying aspect of life is the risk of suicide or self-mutilation. That's your primary step, your first goal. Tell us what you do.
The first thing that I think you have to do is that you have to recognize that if suicidal people could manage their lives and make them bearable in some other way, surely they would do that. Mm-hmm. So you have to assume that they in fact can't do something else that would work. Mm-hmm. So the first thing you have to do is you have to improve their capabilities.
How does one use what you teach in workshops on this tape and in your books? How does one use that in everyday practice with the next patient? If one doesn't have the whole team and doesn't have the total experience in applying the treatment?
I don't know. I would probably respond to that by saying you take what you can get. Mm-hmm. I mean, you take what you can take. I mean, obviously, if you can't do the whole thing, you have to take what you can take, and you take whatever seems reasonable and whatever you think is going to fit into your practice. It's a long-term question, and we have to do a lot more work in research to find out how much of it do you have to get the same results that we got in our research. Mm-hmm. But that research hasn't been done. My personal belief from doing the training that I've done around the country is that almost everybody can take almost all of it. Mm-hmm. Because what most people don't realize until after they've learned it is that before they learn the treatment, almost everybody's doing 80% of it. Mm-hmm. It's not as if this is an entirely new thing. Mm-hmm. If it was, I'm sure no one would like it. It would be too way out. But everyone's doing 80%, so most people only have to learn 20% anyway. Mm-hmm. And so it's just that the 20% one person learns is different than the 20% another person learns. So you need to find the 20% that's not your 20%, see if you like it, and put it in.
Lots of times the individual person or the family loses hope. Sometimes the therapist or even the treatment team loses hope. The long-run prospects for most people are pretty good. how do we somehow or other get people through the rough patches that so often make it difficult when we're seeing them?
If the patient loses hope, or the family, and the therapist has contact, obviously, with the patient, but if they also do with the family, the main thing is for the therapist to cheerlead. So the therapist believes, and the therapist continues to encourage and pushes, cajoles, carries, drags, etc. So then the problem is what happens if the patient loses hope and the therapist loses hope. And that's where this idea of a treatment team comes in. Perhaps we ought to be clear what I mean by treatment team. What I really mean by it, at its most minimal level, is simply another person who's a professional therapist also. So my idea is that every therapist who treats the very severely disordered person needs one peer colleague that they consult with. And the colleague remoralizes, so to speak. That's part of their task. You remoralize for them, they remoralize for you. They carry a magnifying glass, and they're looking with their magnifying glass, trying to find
Where's
the
the hope?
progress, exactly, that you've missed that week. And it can be one person. In my research, it's been a team of about 6. In community mental health centers, it's usually, whatever the team is. And one of the main tasks that they have is to carry a magnifying glass and put it up when you talk to them.
There's always hope if you can just look hard enough for it.
Well, I don't even know if there's always hope. The question is, what's the option? Whether there's hope or not, there's got to be hope.
Marcia Linehan is professor of psychology and psychiatry at the University of Washington in Seattle. She is also director of the Suicidal Behaviors Research Clinic. The principles of dialectical behavior therapy are addressed in more detail in her book, Cognitive Behavioral Treatment of Borderline Personality Disorder, available from Guilford Publications. In addition to this program, there is a companion videotape, Understanding Borderline Personality Disorder, the Dialectical Approach.